Welcome everyone to the July 10th session of the Virtual Learning Collaborative entitled Viral Hepatitis Prevention, Testing, Treatment, and Linkage to Care Services for State and Local Corrections. My name is made possible in partnership with the CDC Division of Viral Hepatitis. So my name is Zakia Grubbs. I'm a manager here on the hepatitis team. So for today's session, we will start with presentations from Shelley Facente and Kelly Burk of Facente Consulting and HepTAC Consultants, followed by a moderated discussion led by DaNae Schoenborn of the Idaho Department of Health and Welfare. So feel free to use the chat to introduce yourselves, let us know what jurisdictions you're coming from, and also if you have any questions during the presentations. So with that, I will, no, it's weird to advance the slides. I will turn it over to Katie and Shelley.
Thank you so much. And hi, everyone. Nice to be here. We're really excited to talk to you a little bit today about an assessment of Hep C knowledge and treatment needs in the San Francisco County jail system. We can go to the next slide. So I am Katie Burk with Facente Consulting, and I've been with Facente Consulting for almost 3 years. We do a lot of work around drug user health and hepatitis and kind of the health and well-being of people who use drugs and people who experience homelessness. And I was previously at the San Francisco Department of Public Health for 7 years as the viral hepatitis coordinator there. So a lot of this work is kind of drawing on my experience at SFDPH and then kind of moving into this role at Facente, where we're able to do things a little differently than they happen at the health department. So we'll talk about that. I want to give Shelley a minute to introduce herself as well.
Sure. Hi, everyone. I'm Shelley Facente, and I also work at Facente Consulting and worked on this assessment with Katie. I am one of the people at Facente Consulting that does a lot of the quantitative data analysis. So I was part of the interviews that we'll talk about that we did that informed this work, but also did the data analysis from medical records and things like that. And so I also worked at the San Francisco Department of Public Health in the years before Katie. We kind of passed there and didn't overlap, but have worked together for many years before she joined Facente Consulting in different ways. All right.
Okay. Thanks, Shelley. So we'll first jump into a little bit of background on this project and kind of what brought us to this work, these particular questions in the jail at the San Francisco Department of Public Health. So just a little bit of information about kind of the San Francisco context. So for folks that aren't aware, NHEP-CSF is the Hepatitis C Elimination Initiative in San Francisco that was established in 2016. It was the first citywide Hep C elimination initiative that I'm aware of. And as part of the work, NHEP-CSF is sort of a collective impact initiative that brings together all of the partners that work on Hep C in different ways in San Francisco under the sort of shared vision of Hep C elimination. So, you know, during those years, those early years of NHEP-CSF, we were making really significant investments in low barrier Hep C testing, linkage, and treatment models. We were kind of always asking ourselves, how can we make Hep C treatment and these new advances in treatment that have been so life-changing available for folks that really need the most help to engage in treatment? And so that involves bringing treatment into, you know, SSPs, into MAT programs, into sexual health clinics. And so over the course of those first initial years when DAAs were available and we had really started to scale up programming, we made a lot of progress in kind of clearing the bottleneck of folks that were waiting for DAAs to be available before they got treated for hepatitis C. And over time, in our conversations with community partners, we kind of started to anecdotally like share this experience that the people who still needed to be treated for hepatitis C tended to be, you know, what you could call the high-hanging fruit, or just people that needed a lot of support to successfully engage in treatment. And that was really our challenge in NHEP-CSF, is to figure out making treatment available to them. And so other important things to know about the work in San Francisco is also in those kind of early years. Well, actually, let me back up and talk about the jails first. So, you know, we know that carceral populations have really high kind of Hep C positivity rates. The estimates for Hep C antibody positivity in jails was about 12 to 35% in the recent studies that we read. So we've actually made more progress in prisons in the US thanks to a number of lawsuits that kind of compelled state-run prisons to buy and offer Hep C treatment to prisoners. That happened in California. So California, at least ostensibly, if you go to prison and you have hepatitis C, you should be treated. There is a budget to treat folks. But in jail, like jail-based hepatitis C treatment is a little bit more complex, right? And that's because when people go to jail, they lose their public benefits. And so the people that are running the jail in San Francisco, for the San Francisco County Jail, that's the city that's running the jail, right? They have to cover the cost for any kind of treatment or medications that folks in the jail are on. So that's one big hurdle to sort of Hep C treatment in the jails. The second hurdle is that many people in the jail, particularly in San Francisco, are there for very brief periods of time. And so they might be in and out in a day or in and out. I think the average stay was like 3 days when we started this study. And so, you know, that could have changed in the last couple of years, but it's generally not people are hanging out for 12 weeks to finish like a 12-week treatment course or 8 weeks to finish a 12-week treatment, 8-week treatment course, excuse me. Next slide. And so something that was interesting that we, that was part of NHEPC's work was in 2017, the city actually received a Gilead fund to run a study on Hep C treatment in the jail. And what the study was really aiming to do was to look at kind of comparing people who finished treatment, you know, over the period of their incarceration versus people that started treatment in jail and then kind of finished their meds when they were out in the community. So there was 99 people treated as part of the study. 49 were released during the course of their treatment into the community to finish treatment there, and the other half kind of remained in jail for the course of their treatment. And so overall, the SVR rate or the cure rate was about 78% of people achieved SVR through the study. And that looks different among the people that remained incarcerated versus the folks that were released, right? So unsurprisingly, like 90% SVR rate among people who remained incarcerated during the course of their treatment. And for folks that were released into the community, it was still a 65% SVR12 rate among people who, you know, weren't able to finish their treatment in jail. And so I think this is still impressive given that, you know, post-release time in jail it can be a really chaotic time for folks, right? Especially if there are people experiencing homelessness and people that may be kind of chaotically using substances. So kind of recognizing this progress and the sort of importance of Hep C treatment in January of 2022, and following, honestly, a lot of advocacy on the part of NHEPCSF and internally within jail health, I think, the city added some funds to its budget to offer treatment to 12 people per year through jail health services. So we know that's better than a lot of jurisdictions have in terms of availability for Hep C treatment in jail. But we also saw that this resource was really easily exhausted by June of 2022. So 12 treatment courses did not get us through half the year in San Francisco. And so we were really interested in this because we knew, A, that the city recognized that this was important enough to put some money into this. B, they didn't resource it adequately, right? So we couldn't treat all the people that needed to be treated in jail. And we also kind of always were noting that 100% of people living with HIV or STIs in jail are automatically treated without regard to cost, right? So what's different about Hep C? We wanted to kind of explore that and learn a little bit more about that. Next slide. Okay, so what did we do? So NHEPCSF has a few different work groups, and one of them is the Community Research and Data Stewardship, or CORDS work group. And that group kind of, you know, looks at all the surveillance, is mostly epidemiologists and people that do research around hepatitis C, and they commission the needs assessment to better understand what was going on with Hep C knowledge and treatment readiness among people who were incarcerated in the San Francisco County jails. So we had a funder at NHEPC, SFCAN, which is an initiative at UCSF that seeks to reduce morbidity and mortality among preventable cancers for people in San Francisco. And we're fortunate that NHEPC has been funded by SFCAN for many years. And so SFCAN provided, you know, kind of a modest budget and commissioned Facente Consulting to really explore this. So we did 31 interviews with surveys with people who were incarcerated in the jail. So we went into the jails and talked to folks that were there. We did 6 interviews with the staff of jail health services. And as Shelley said, she did some analysis of the clinical data looking at the time period of January 2016 through September of 2021. Next And so what we were really hoping to do was kind of fourfold here. One, we wanted to identify gaps in Hep C testing and treatment in the SF County jails. Two, we really wanted to assess readiness to scale up Hep C treatment. So like if we could even get more meds in the jail, are they ready to treat more people? Three is we wanted to identify best practices for treatment and linkage, but really from the perspective of folks that were incarcerated and living with hepatitis C, like what would work for you guys best? And then four, we wanted to develop a Hep C care cascade for people currently or recently incarcerated in the in the San Francisco County Jail. So next slide. So who did we talk to among the 31 folks that we talked to? So 87% of them were cis men, 3 were cis women, 1 identified as a trans person. 36% had active Hep C infection. You know, there were 3 people that were actively on Hep C treatment, or 3%, which I think equated to like 1 person was actively on Hep C treatment at the jail. 29% had already been cured of their Hep C. 16% had never received a Hep C diagnosis. About half the group was white, with about 19% of folks being Black and 13% being Latine. So almost everyone, 97% of people we talked to had been incarcerated before. 65% were homeless when they were arrested, and another, almost 30% had been previously homeless. So this was a super vulnerable population, right? There was a really high prevalence of hepatitis C. Most were homeless and had been previously incarcerated. So the way that we selected folks is first we tried to talk to people who we knew were Hep C RNA positive or were on treatment. And then when we ran out of folks that had Hep C or were actively being treated for Hep C, we recruited folks that had opioid use disorder on their medical problem list. And we kind of used that as an imperfect proxy for hepatitis C risk. And the only way we were able to do this, and I think we'll probably emphasize this a couple of times during the presentation, is that we were working in partnership with our jail health staff person friend named David Leva, who I will just shout out because he was wonderful and so helpful. And he's a coordinating committee member of NHEP CSF. So he's already a part of sort of NHEP CSF, but he was like really, really crucial to the project in terms of helping us with access and identifying folks to talk to and bringing us around to find them and speak to them. Okay. And I'm going to turn it over to Shelley to talk a little bit about findings.
All right. So Katie just went over the demographics of who we interviewed, but I'll talk a little bit about the demographics overall. When we looked at the medical records and we looked at everybody who had been tested for Hep C in the jails compared to everybody who was incarcerated and then those who had been tested, what do we see? So on this first slide, you can see just the total numbers. And so you can see in 2016, when we started looking at this, there were about just shy of 10,000 people incarcerated in the jails and about a little less than 2,000 antibody tests for Hep C were done with a 13% positivity rate. And over time, the total incarceration rate went down. It was a little, and then in 2020, there was a big dip, which obviously was COVID related, you can all imagine. The last row here is actually only 9 months. So that's important because at the time we did this, we only had 9 months of medical record data because they actually switched systems at that time. And so we just, so it's a partial year. But you can see the positivity rate also went down, but this is in large part because as they were testing people, this was an opt-in. This wasn't like a test that everybody got at intake. This was something that people either self-identified or there was some reason to do outreach. That the idea was that people maybe had higher risk for Hep C, and so they were actively offered a test. But if someone was already known to have Hep C, then they didn't get tested through this program. There wouldn't have been a good reason for that because we'd know that the antibody result was positive. And so the fact that the numbers started going down of antibody positivity isn't reflecting that there's like less history of Hep C among people in the population. It's that there's actually fewer, like the pool of people who are undiagnosed but antibody positive was shrinking, which I think is really likely a direct result of this active work that they were doing in the jails to do testing. So on this next slide, I just want to lift up one demographic before I get into some of the other findings from our interviews. And that's to say, we looked at trends in Hep C testing and positive results by a number of different demographics. For time, I won't go over them. But one that's really worth highlighting was the disproportionate number of people we found to be unhoused at the time of arrest for those who tested Hep C antibody positive compared to those who were incarcerated overall. So you can see here, incarcerated overall, about 1 in 5 people were homeless at the time of arrest in the San Francisco jails. A little bit less than half of the people who were tested for Hep C antibodies were homeless at the time of arrest, but about 2/3 of the people who tested antibody positive were. And so that just felt like an important finding to really be thinking about what risk is and how to prioritize limited testing resources for folks. Okay, so now I'll talk about a few of our findings around gaps in Hep C testing and treatment. Between 2016 and 2021, this period that we were looking at the medical data, 15.9% of people who are incarcerated were actually screened. So a little bit less than 1 in 5 were screened for Hep C antibodies. The jail had been doing lab-based testing, but they switched to rapid testing during this time. And so there was the uptake increased because they didn't need licensed phlebotomists to actually do the testing. And it was preferable to many of the folks being tested to have a finger prick as opposed to a painful blood draw. So by the end of this period, in the first 9 months of 2021, that number had more than doubled to 34.7% of people who were incarcerated that were screened. And so when we did the interviews, we heard from people having rapid testing with a finger stick is pretty critical because people don't always want to get a blood draw. So it's a good method to get results in a reliable, I think that's supposed to be manner actually, so people know their status quickly. We still test a lot of people who don't test anywhere else. Lots of folks who are homeless or using substances who have other priorities. It's a good opportunity to let folks know the testing is private and free and we can connect them to services. All right, so then we heard some other things about treatment. And essentially we heard from people, sort of a little bit the opposite. Like treatment is not going great. We have the opportunity to do it. We just don't have the meds. We definitely, with everyone here, we can treat Hep C. It's so easy to do with the medications. If we had more of the meds, we could definitely treat the guys quicker. And someone else said, everybody wants to help the jail, but when it comes down to really helping the jail, nobody wants to help the jail. We could just pay for Epclusa. You can have all the linkages you want, but unless you're going to handhold somebody, jail is a very good place to treat. But there's all this virtue signaling, and then no one really wants to pay for the treatment. We just need to take the risk that someone may not finish treatment. We can treat people, and we do this all the time with HIV meds. And so that really became sort of a theme for a lot of what we talked about and sort of underscored the conversations that we had with people who were incarcerated during the interviews as well.
Okay, so one other thing I'll mention is that we had a series of questions to assess whether folks who are in the jail actually had accurate and kind of up-to-date information about hepatitis C or not, and generally found that folks had fairly strong knowledge about hepatitis C. So you can see this is kind of a summary of the kind of knowledge points we were assessing. And this felt really important to us because we wanted to ensure that lack of engagement in services wasn't about sort of lack of awareness or misunderstanding about hepatitis C or, thinking that the only option was interferon-based treatment or other kind of outdated information. And so by and large, we found that not to be the case and that it was a pretty well-educated group of the folks in jail about hepatitis C. So that was helpful to know. And then the other thing I'll say is we kind of asked folks, okay, where would you want to be treated for hepatitis C? And we gave folks a list of options. And the most popular option was jail. 8 people of the 31 said jail was the best place for them. And someone kind of summarized that saying, if I was in jail, I'd want to be treated in jail. I guarantee I could get the pill every day. And so that kind of speaks to the flip side of that reality, right? Is that if you're out in the community, if you're living on the streets, if you have a lot going on in your life, like there's no guarantee you're going to get to your meds or remember to take them every day, or that they won't get lost or stolen when you're vulnerable. And so people really knew that and understood that jail represented an opportunity really for like directly observed therapy. And then you can see here the other places we asked folks about, you know, where they would be interested in being treated. So after jail, the next most popular answer was syringe service programs, the methadone program, then the community behavioral health pharmacy in San Francisco, or their primary care provider. And so folks were generally interested in being treated somewhere where they already had connections to other services or care, right? So they're like, yeah, I go to the syringe service program almost every day, and so I could just get my medication there. But people were also aware that it would be trickier to be treated in jail if they were to be released before their treatment was up. So a lot of folks said, like, yeah, I'd want jail to be the place, but like if I was going to be here long enough to get treated. And so one person said, if someone is serving 8 weeks to 90 days, they should be offered HepTAC treatment right away, and they should be given the opportunity to take it. And anyone else not staying that long should be given the opportunity. And if they don't want to start it here, there should be somewhere outside where they can start it. So they're like, give us options, you know, have plans for us based on where we are. And then, you know, Shelley sort of alluded to this already, but we really found that jail health staff were just frustrated by the lack of meds. And so, you know, it was kind of like the opposite problem in community settings, like barriers to treatment include competing priorities for patients, like folks not being able to make it in to see their care provider. Maybe this provider might not be willing to take treatment on for folks that have been kind of inconsistently engaged in treatment. But in jails, the problem really was like lack of access to the curative medication, you know? And so one of our providers said, some of the folks who have severe mental illness or substance use, they'd be good to treat in custody because they have a chance to stabilize a little bit. Sometimes the more unorganized folks could be more successful if they're treated in jail. At least when they're incarcerated, they might connect with medical providers more frequently. So remembering that demographic slide, remembering that, you know, almost everyone we talked to was homeless when they were arrested, that people had a lot of experience with like multiple stays in drug treatment. Like, again, this is a very vulnerable subset of folks that just need a lot of help, and the jail health staff really kind of recognize that. Go ahead, Shelley.
Okay. Yeah. Okay. So now we'll talk about that third point we were aiming to understand better, which was best practices for treatment and linkage to treatment. And so, you know, research has conclusively demonstrated that people who struggle with disordered substance use or who are unhoused or marginally housed can be treated much more successfully when treatment is integrated at a place where they're already engaged, rather than relying on someone to help them navigate to get from one place to a different place to actually get those services. And, you know, linkage services are important. And we have linkage services in San Francisco that have helped hundreds of people being cured of Hep C. But for some folks, those types of services just aren't sufficient support for them. And wherever folks may engage are the best places to treat them. So we heard from one person who was incarcerated, the closest I got to being treated for Hep C was a clinic outside of here. They gave me the pills. I had the pills. I didn't have a backpack. I was carrying my sleeping bag and I had the pills in it. I fell asleep and someone stole my sleeping bag and the pills got stolen from me. That was the closest I had ever gotten to any kind of cure. So those kinds of stories, of which we heard many, were you know, just more reason to really follow the science, to hear that this is the way to treat people most successfully. And so, you know, people in the jails indicated that they'd like some help to be treated in the community if they're not going to be treated in jail. So they were really interested in having a navigator who was like personally assigned to them, who they knew that they could reach out to, having daily reminders to take meds in some kind of way, talking to someone who had been treated before. Several people also suggested medication lockers, even though that wasn't one of the options that we specifically were sort of providing them in the multiple choice. They said, you know, if I had a place where I could lock up my meds and store my stuff, that would be really helpful. So these resources already exist, including the medication lockers. They already exist in the community in San Francisco. We're really fortunate that there have been these types of services. There are numerous organizations funded to do these types of things. but many of our interviewees were just unaware of that. They were like, oh, that would be amazing if I could access that thing. And so it was very notable that it felt like a new idea to the folks that we were talking to, and just really showed that sometimes those services existing isn't quite enough. And so basically the bottom line was that existing community supports just aren't enough for many of the people we interviewed. We found that when we looked at the medical data, that 56%, more than half of the people known to have Hep C in the jail, remained untreated for that chronic infection, even though these types of services have been out in the community for a long time. And so, the bottom line is what you see in this blue square. San Francisco has spent millions of dollars on these community supports, and most people that we interviewed didn't know they existed. So there's something, the link is not there, and we really have to be more thoughtful to figure out, if we're not treating in jail, then how do we make the community supports on the outside actually work for people who are being released from jail or maybe cycling in and out of jail. Okay, so then the fourth question that we were looking at was around the Hep C care cascade. And so we really wanted to see, like, what does this look like? So you can see here, of the total number incarcerated, about 16% of those were screened for antibodies. And a little more than half of those who tested antibody positive actually got confirmatory testing. They got RNA testing in the jail to confirm whether they had active infection. But for those who had confirmed infection, only 8.7% were actually treated for their Hep C, even though this was a time where the treatment was available, at least for some number of people. And so this 8.7% of people are treated in jail, and that's 28 people who were treated. But it's really important to note that there were actually 115 total people with positive antibody results whose sort of last known status was listed as cured. So that's, or no longer RNA positive. And so that's 87 more people on top of the 28 that you see here, who either spontaneously cleared their infection, which is probably not that many, but some, or they were treated and cured out in the community, probably most. So this isn't to say that folks can't be treated outside in the community. That's certainly happening. But knowing that it's much easier for people to be successfully treated while they're in jail, or at least started in jail, that's not happening nearly as often. So then we looked specifically at missed opportunities. We said, okay, how many people were incarcerated for 60 days or more after they received a positive RNA test result in jail, but there was no indication of them having received treatment or clearing the virus? So these are essentially people who were identified in jail as having active Hep C infection, and then from that point were incarcerated long enough to have been treated and cured, but weren't. And what we found was that there were 79 people who, in that almost 5-year time window we were looking at, fell into that category. So they were known to be living with Hep C while incarcerated. They were in jail long enough to be cured before release, but they weren't. These are true missed opportunities. So there were 7 people of these 79 who had 2 windows of time like this. This was twice 2 missed opportunities for them. 3 people had 3 windows of time, and 2 people had 4 windows like that when they could have been cured. So 4 stretches when they had been identified as having known Hep C infection, but weren't treated. And so, then we said, what are the implications of that? And there are studies that show, there aren't studies about this particular number, but there are studies that show that people who inject drugs in high prevalence communities in San Francisco, which we were using as sort of the best proxy we could come up with, on average, pass on that infection to 2.08 more people on average if they're not treated and cured. And so essentially, having treated and cured these 79 people while they were in jail, while they were there and able to be treated and known to have Hep C, it could have likely averted another 164 new infections in San Francisco. And so given how much is being poured into this Hep C elimination initiative, this is really a very important missed opportunity. All right, now I'll pass it back to Katie to talk about some of our recommendations that came out of these findings.
Okay, so we thought that these were kind of really interesting findings. And the first thing that we want to point out, and we know that we're preaching to the choir here, is that, you know, jails are the place to treat Hep C, or at least a place to treat Hep C, right? So they offer the best opportunity to treat many of the folks who are in jail and living with hepatitis C, particularly because these folks have a tenuous or non-existent connections to community care. And some of the things that we explored in the survey was sort of like, have you been in jail before? You have? Okay. Last time you got out of jail, did you go see your doctor? You know, why not? And folks were just kind of like, I had too much going on. Like, it didn't feel important. I wasn't sick. I didn't go to my doctor. And so again, here at jail, particularly for this extremely vulnerable subset of folks that are in jail that have hepatitis C, there's a great opportunity to address their hepatitis C while they're there, and, you know, for better or worse, stuck there for the length of their sentence. And then we made just kind of three recommendations. We didn't want to kind of overcomplicate this, but the first being, you know, kind of a non-brainer, that we really need to increase access to jail-based Hep C treatment for everyone whom the jail health team deems eligible for treatment, right? So San Francisco's work to really liberalize community-based Hep C treatment, you know, in settings such as syringe service programs and methadone programs and primary care, had already delivered treatment to hundreds of really vulnerable San Franciscans with hepatitis C, and those are important victories. And there are still folks being left behind, and this is the opportunity about where to catch them, you know. And one of the providers, one of the clinicians who's also a lead in NHEP CSF, had talked about in her work, she worked on that 2017 jail-based study, and she just said, like, you're not going to catch these folks anywhere else, you know, like, this is our chance to treat them. And then we also thought that, you know, given the fact that folks were asking to engage in services that existed in San Francisco and had existed for like a couple of years, that we really need to adjust community-based linkage systems in San Francisco to better serve people that are stuck in that cycle of recidivism. So make sure that people know about the services, are getting kind of proactively linked to them, and that, you know, sort of competing needs around securing basic necessities could be kind of like the work to meet those needs could be integrated into their work to cure their hepatitis C. And then we also thought it was really important to continuously monitor the data of the Hep C care cascade within jail health services. It felt like we learned so much from Shelley's efforts to really go through that and look at, like, how many people were treated based on the people we know that have Hep C in the jail. Like, are they being treated in the jail? Are they being treated in other places? Like, we need to continue to ask those questions in an iterative way in order to make a meaningful dent in this issue.
Okay, so as our last section, we wanted to talk about data for advocacy, because we, you know, it's not useful. We're trying to get this paper published, but we don't believe these data are valuable unless they're driving change. And that's really what we set out to do with this project. So we wanted to be transparent about our findings as soon as we finished our analysis and report. As Katie just went over, we did have some specific recommendations, and the goal was to make those recommendations. But we really wanted to think about the process for sharing results and who we involved and how that happened. So it's important that first we presented this to jail health staff. Sharing results with jail health staff as a partner was really important. We didn't want them to be surprised or feel like anything was represented inaccurately. And they actually did have a few easy changes to make that were important reframes of the information and the way we talked about it. So it was very valuable that we started with them before we went anywhere else. Then we went and shared those findings with NHEP CSF, who had kind of commissioned this to happen in the first place, ensuring that advocacy for jail-based Hep C treatment really remained a central part of the group's advocacy priorities, that it could fuel, you know, the recommendations and the advocacy by using data and having them have something concrete to grab onto, rather than just saying, this is important, it should happen. And really importantly, the medical director of Jail Health Services did some internal advocacy. He now had data to support his ask for increasing access to treatment for people who are incarcerated, which he had been talking about for a long time. But again, he had that data to grab onto. And he really succeeded in accessing increased funding for Hep C treatment in the jails. The decision was made internally to identify reducing Hep C treatment disparities among people who are Black, or African American, Latinx, Indigenous Americans in jail. They actually picked that as one of their true north goals for the year in 2023, I think. And so now they're really treating a lot more people per year, and that did arise directly from this. So since January of 2022, they've actually been able to do 85 treatment starts. They've had 67 people complete treatment, 9 are still on treatment, and only 8 people left with incomplete treatment, and as far as they know, weren't able to complete the treatment. So this is really a pretty exciting success story of how the data can be used to bring about positive change. So now we just want to talk as our last slide about some lessons learned, or as we're calling it, it's nice for San Francisco, but we don't have these resources in my jurisdiction. Like, thanks, but we can't do something like this. We really think that's not true. There are things that can be done, even if you don't live in San Francisco or a city like San Francisco. And so we wanted to share these 4 key lessons learned that we hope feel more applicable to you. So the first, as Katie already said, this would not have been possible without our man on the inside, David Leva, who works at Jail Health. But we didn't just reach out to him in order to get help with this project. We already had a relationship with him. When Katie was the viral hepatitis coordinator, she would go give hepatitis education sessions in the jail, for example. And so we already had these relationships, not just with him, but with others at jail health staff. And that made it much easier to say, okay, this is what we want to do. Let's work together. There was trust built and an understanding of how to work together successfully. So investing in those relationships is really critical. The second one is around doing your homework about local service options and really thinking about what else exists outside the jail. As we've said, we are fortunate in San Francisco because we've done lots of work to create community-based Hep C treatment options in syringe services programs, methadone programs, shelters, things like that. And we still found that that wasn't enough for the folks we were talking to in jail. So this was a subset of people who use drugs or people experiencing homelessness who just couldn't make that existing low barrier, those options, they didn't work for them. And that was an important learning for us. So many of your communities have FQHCs or others. You may be doing crucial work around Hep C interventions, but we've got to continuously interrogate who is being left out. Who are these services actually serving, and who are we totally missing, and what can we do differently with that? So that's something that any jurisdiction can do. The third one, we didn't actually seek IRB approval for this because it doesn't meet the criteria for human subjects research. It's programmatic evaluation for public health purposes, not a research study in itself. And so, all of you in health departments are equipped to do this kind of assessment work. And a lot of times people get stuck feeling like, well, if I'm going to talk to anybody, then that's human subjects research. Then I have to get IRB. That takes months and months, or it takes a long time. And so really trying to better understand, and often you can consult with someone in a local IRB to say, is this actually human subjects research? Do I have to go through this process, or do I not? That's important. You can also ask for support from HepTAC to help develop surveys, interview tools. And so all of this doesn't have to be a formal, scary process. It's really asking people what's working, what's not working, and what could we be doing differently. And that's something all of you are certainly capable of doing, even if you don't have a research infrastructure. And then the fourth one is really around, being strategic about how results can support or drive advocacy efforts. We didn't do a big press release or try to embarrass the Department of Public Health with these results. That was a possibility. I mean, it was something we talked about briefly, like there's some stuff in here that feels horrifying. What if we just put things on blast? But we really said, I think that's gonna cause more problems than it's worth. The data are compelling to affect change if we use it thoughtfully and we don't get people in a defensive, embarrassed state. And so we really fed it to the folks that we thought could drive that process along. And we found that, you know, with good numbers and support and how to do that advocacy, it was really very successful for those purposes. And so, so just thinking about how to use those results in the best possible way to drive change is another thing that any of us can do. All right, so those are our lessons learned. And I think at this point, I'll stop sharing, and Katie and I are happy to have some discussion with you all and open this up.
Okay, hi everyone. There is a question in the chat that Lisa brought up, and she said, is the total incarcerated including people that were identified as positive the year prior?
Yes, thank you for that question. Yes, so we just said, like, who's everybody who we have any record on, how many people sort of interacted as an incarcerated person in that jail system during this calendar year. That number was counted. So the total incarcerated includes anybody. It doesn't count duplicated people. It includes like each person who appeared at least once, but we didn't exclude people because, for example, they had already been identified as positive. So that's why you see that drop in positivity rate over time, because we weren't shrinking the denominator accordingly.
Okay,
Great
thank you for answering that. All right, and then thank you, Zakia. So in the chat, she did say, feel free to add any questions in the chat or raise your hand or unmute yourself. But in the meantime, there's just a couple of other questions that have come up. How can health departments foster relationships with local jail and involve them in coalition activities? So when you're building, you know, these hepatitis elimination plans in your community, how can our health departments foster those relationships with our local jails?
Yeah, I mean, I can speak to some of the strategies that have been helpful for me, and I think there's lots of things that folks can try, but like when I started as a viral hepatitis coordinator, I just kind of thought a lot about all of the kind of high impact places, I think is what the CDC calls them, right? Where folks that are at risk for hepatitis C are more likely to be experiencing substance use or other factors that kind of put them at higher risk, and just kind of started reaching out to folks. So reaching out to people at MAT programs and harm reduction programs and the county jail, and just kind of asking to have introductory meetings where I'm like, oh, I'd love to learn about your program. I'd love to learn about if you're doing any testing, what that looks like, how people are selected for it. I can tell you a little bit about the priorities of the health department. And so I did a lot of that, just kind of, can we have coffee? Can we chat over Zoom for a little bit to try to get A, a better understanding of the landscape, but B, once you do that, you sort of can start to pick out folks that are really committed to the issue and really interested in upscaling and program development, and figure out ways to kind of, I think, draw on them later. And so I think it's a lot of just kind of like knocking on doors, learning about what the programs are, figuring out if there's ways to, if you get CDC funding, if you get funding from your state or your local jurisdiction, if there's ways that it makes sense to kind of align your purposes around Hep C treatment programs. And so obviously it's great if you can fund folks, right? And then they have to report data and be accountable. I know that that's not always possible given sort of the limitations with hepatitis funding. But another thing that happened in San Francisco is we had done a lot of this pre-work and done a lot of visioning about how to make treatment more accessible for folks. And then when the state released its first RFP, I think around 2016 as well, for Hep C testing and linkage, like pilot jurisdictions, we were ready to go because we had already talked about what we would want to do when we had resources. So I know a lot of times it kind of goes the other way, like you get a grant and then you figure it out. But if you do a little like relationship building, sort of identification of where folks are really ready to scale up, like sometimes funding becomes available down the road, or there's like carry forward funding or something that you kind of have like some ideas locked and loaded and ready to go.
That's really great. Thank you. We have another question in the chat. Now, this is something interesting because this kind of goes into what we're experiencing in Idaho. But from Shamia, it said, can you expand on what funding was used for treatment in the jails? We have jails that are interested in treatment and health district staff that are willing to assist, but the large challenge is funding within the jails. It is my understanding that patient assistance program is not an option for those incarcerated. Is that what you found as well? We have found that as well, that patient assistance doesn't work when folks are in the county jail setting. But what's interesting about it, as soon as they get out, once the local health district starts treatment on them, they can do patient assistance and it works once they're out. So I guess for me, for ours specifically, that's where we reached out to Gilead, because in the patient assistance, it never once said if they're incarcerated, they're ineligible. So our health district staff filled out the patient assistance while the person was in the local county jail. It came back denied because of that jail status. So she knew when they were going to get out, and she already set them an appointment to come to the local health district. She got them linked to the local health district, went ahead and initiated patient assistance, and was able to help that way. But I wish there was something we could do with like Gilead to not deny those folks that are incarcerated. But I don't know if you have any questions of how the San Francisco County Jail was able to fund those 50 folks to be treated.
Yeah, I mean, a couple of things. We had leaned on several patient assistance programs pretty hard and was trying to figure out if, because it does seem like, hey, it's supposed to be for uninsured people. Everyone in jail is uninsured, you know. And we actually got, I don't even remember, I would call it out if I can remember, but one of the companies we got pretty close, and it seemed like they were about to treat someone, and then I think somewhere someone realized the implications of that and they pulled back really fast. And so we had tried the patient assistance program route as well, and just ultimately kept coming up to like the only option is if the city paid for that. And so the funding for the jail came out of city general fund. It came out of the jail health pharmacy budget. Again, I think it was related to, and I'm not sure honestly about kind of what the internal process was to come to that decision. I mean, I know that there was some internal advocacy happening with the medical director of the jail health staff. I know they were able to use our data to support that. And I know that having the overall director sort of identify reduction in sort of treatment access disparities among different racial and ethnic groups was a big driver of like the justification of that going into the city general fund pharmacy budget. But the city just paid for it as part of the budget that they pay for any medications for folks that are in jail, which I know also is very unique and fortunate for San Franciscans.
Yeah, I think I might just add two quick things related to that. One is, you know, the same challenges are true when it comes to HIV medications and other things. It's not like, oh, those are all covered, but the Hep C meds aren't. And so that I think has been a helpful advocacy tool, because there was, at least in San Francisco, there was never any question about providing the HIV meds. So it's like, okay, well, that mechanism is working there. So this one, it's a matter of deciding this is important enough, and sort of talking about the benefits of, you know, this is an opportunity to actually cure someone of a disease for which there's pretty high burden, especially among this population. So some of those conversations could help, although it's not easy to do advocacy around this. The other thing I just want to add is that one thing that's unique about California is that they've applied for and successfully received federal approval for a waiver related to Medicaid, which is called Medi-Cal in California, where I don't actually think it's in place yet, or it's sort of on the cusp of being active, where there are a targeted set of services that are available to people who are in correctional facilities up to 90 days prior to release, where Medi-Cal will actually kick in again. Of course, that's really logistically challenging in jail, where you don't really necessarily know that someone is 90 days away from release, or it might not apply, right? It's much easier to apply in a prison setting than in jail. But this is sort of a new thing that people are figuring out. And so that is very interesting. It only applies to California at this point, but it might be a model that other states could at least think about for similar waivers.
Yeah. Shamia, go ahead and unmute yourself. It looks like you're raising your hand for a question.
Yes. So, thank you for answering the question related to funding. Two things. One, I think that unfortunately in our area, it seems like jails are almost hesitant to even test folks for hepatitis C because there's this idea if I test them, I have to do something. And the linkage to care piece is as, critical as we know it is, and it would be great to get those appointments, before they're released, things like that. That seems to not fit what they feel like is the definition of addressing hepatitis C. And there are these barriers to funding when it comes to actually treating within the health departments, as you kind of mentioned, and totally agree with everything you said. So sounds like we're not the only ones. So I guess my question is two things. When you talked about being able to do linkage to care as well as treatment within the facility, how did it go about navigating, like making sure that treatment is done within a jail setting before they're released? Because that was the other piece that they kept saying, well, we can't really even do this because we don't know when they're going to be released. Because we did do a pilot where we tried to at least get someone linked to treatment. And that was one of the challenges. And when you're talking about, Medi-Cal, I think you said picking up like 90 days before, are they doing testing closer to when they're released? I'm just curious how you're kind of navigating that piece.
Yeah, I think that, first of all, I want to just say that I think that this is definitely imperfect and not at all seamless in San Francisco, and that we've tried a few things over the years. When the jail health study was kind of operating in 2017, there were 2 navigators that were funded as part of that study that were kind of in and out of the jail. And so when people got released at weird times when no one thought they were going to get out, which happens in the jail all the time, right? Someone gets let out at 4 a.m, a week before you think they're going to go. The navigators would have done work where they kind of talk to folks where do you hang out? Where do you think you'll end up? If you get suddenly released. And so we really had navigators, and there were 2 of them, and they were at the time on the street hunting people down, trying to get them to these appointments, were very, very actively engaged. And then when that study ended, those particular positions went away. But something that I was able to do in the health department position was leverage some grant funding for a position in the jail that was half overdose prevention kind of education and getting the lockdown into people's personal items for when they're released, and half Hep C linkage. And so they could kind of look at the data, see you in jail, had Hep C, go talk to them about kind of, are you getting care anywhere? Where would you want to go? Try to do some kind of pre-work. We've also done a little bit of having navigators from the community that worked at some of the CBOs that offered treatment at SSPs, for example, that would come in and meet with folks to just kind of create more of a this is the person you go to, this is who you talk to when you leave. And just to kind of do that a little bit proactively and regularly, knowing that it's kind of unavoidable that people will get released at crazy times and, when we don't expect it, to have already had that conversation and gotten some information to them. I think there's also been, as part of the study, I'm not sure how much this has persisted in practice, but they sometimes would make appointments for people to go to and be okay, go to the Tom Waddell clinic, when they're expecting you, and try to have an agreement with some of the FQHCs to be a little flexible about appointments and let people kind of drop in when they got out. And so there's been a lot of efforts to kind of bring the community into the jail, bring folks from the jail out into the community, do some education, set stuff up. And even with our best efforts, it's been, I think, really imperfect. It's still when people get out of jail, usually it's generally a really chaotic time. But sometimes folks disappear for a few days and then they sort of resurface and show up at the clinic, and so just being open to all possibilities around that.
Yeah, I wanted to also kind of follow up with what Shamia was saying. So in Idaho, when our public health nurse, she goes in and she does the HCV screening with a point of care test as well. And it is opt-in. So the folks have to, the residents in the county jail do have to ask to be screened. It's not not everyone is screened. But when they are screened, she does screen them, and then she does ask them when they think they're, if they know their release date and when they're going to be released, and the good majority of them have an idea and have a sense of when they'll be released, how long that they'll be in there. And so if they're going to be released fairly soon, that's when she just goes ahead and she schedules an appointment to come back into the local health district. So I think that's one way where you can kind of try to link folks together, and link them back to the health district if you can't do anything in the county jail setting. So that's one area that we're looking at as well, is just to really follow up with that point, or with that linkage to care piece. Okay, so in the chat we have, this is from Lindsay. Hi, can you talk a little bit more about the navigator approach to encourage or educate people to connect with care? Were there a lot inside the institution, or was it more of like a visitation room?
Yeah. Hi, Lindsay. So they were allowed in the jail. So that was, again, the benefit of having our close relationship with David, who works in jail health services, where he was super great. Like when I went into the jail as a viral hepatitis coordinator to do education groups, he would help you get a temporary clearance or a permanent clearance. Like he would do that stuff, and it would, it would take a little bit for them to do the background check. But David brought lots of folks in from the community to sit down. So there's been different kind of efforts within the walls of the jail, like within the confines, where you do kind of education groups. Like we used to do things where I would do a little bit of a talk about Hep C, and then Dave would hang out and like be like, does anyone want to test? Because we'll sign you up. And then, and a bunch of people would take him up on it, and they test people in the jail. And then that Hep C part overdose coordinator, part Hep C linkage coordinator, did a lot of work in the jails, again, to identify folks with Hep C, to go talk to them, to kind of see, are you already connected to care? Where have you been? Where would it make sense for you to go? And then when the navigators from the community came in, they would get temporary jail clearance, and David would kind of, he comes down and meets you in the lobby and like gives you your temporary clearance and brings you up into the jail. And like, for any of you that haven't been like, have never walked in a jail, it's confusing. Like all the, obviously all the doors are closed and locked. And so to have someone kind of be your tour guide and bring you in and just make the process to get in there really easy was huge for that. But I don't think there's ever been any kind of like Hep C counseling in the visitation room. It's always been sort of in the pods where the folks are hanging out.
Perfect, thank you. Do we have any last minute questions, or please feel free to leave another question in the chat here before our time closes, and feel free to raise your hand if you have a question as well. I want to thank Shelley and Katie for the work that you're doing. It's a wonderful insight and information for all of us to continue to work with our local county jails and continue to use them as a way to connect folks with care. And it's wonderful work that you're doing, powerful work. I'm excited to learn more and hear more as we go along as well. So thank you so much.
Thank you.
All right.
Yeah. Thanks for having us. Thanks everyone for listening.
Yeah, I echo that, DaNae, and thank you all so much for presenting. Thank you all for the questions. And yeah, I guess we can end there. As always, if y'all have any other further follow-up questions, let us know and we can follow up. But yeah, thank you all so much for sharing about all the great work you're doing, and thank y'all for questions. And yeah, all right, everyone have a good afternoon.
Thanks, Paul.
Thank you.